Good morning. We'll continue to talk about diagnosis of the heart pathology, and today we'll stop on the auscultation of heart murmurs. First of all, I want to remember you order of heart auscultation. We'll start from the heart apex where auscultated mitral valve and will be given characteristic of first sound. Then we'll auscultate heart base, which includes aorta, right eight of sternum and pulmonary trunk, left eight of sternum, along second interspace, we will be given characteristic of second sound and finish with auscultation of base of xiphoid process. For auscultation tricuspid valve, we will be given characteristic of the first sound. Last lecture we said about characteristic intensity of the first and second sound. And we are talking about normal intensity of the first sound, which may be characterized only over heart apex and xiphoid process, and normally it must be 2 times louder than second one. If the intensity of the second sound more or less than 10 times over second sound intensity, we are talking about decreased or increased intensity of the first sound. When we are talking about intensity of the second sound, which given over heart base, where we'll auscultate aorta and pulmonary trunk, normal intensity of the second sound when its loudness 2 times more than first sound. Each is normal. But sometimes between main heart sound we'll hear additional sound, which is called as murmurs. And if we'll draw graphic characteristic of the sound, for example, auscultation of the heart apex, where first sound 2 times louder than second, and between them no any additional sound. On the graph, no additional vibration. If you see on this graph, between first and second sound, you see additional vibration. And on auscultation, we'll hear additional sound, which is called as murmur. And if you remember, during last lecture, we said that when we hear first sound, it is audible contraction of atrium and ventricle, closing of the atrioventricular valve, and vibration aorta and pulmonary trunk. Second sound, it is audible closing semilunar valve and vibration aorta and pulmonary trunk. What is murmur? What do you hear? I want that you understand. When we'll hear murmur, it is audible turbulent movements of the blood. Normally, blood go with laminar movement, which are not audible for our ear. In case when the blood will go with turbulent movements, it becomes audible and will be assessed as murmur. Other word, murmur is audible turbulent movements of blood. And when we'll hear murmur, we must find source or origin of these turbulent movements, provoke factors which change laminar movements of blood. Heart murmurs depending of the location or the origin, divided on two groups. Endocardiac, which appears into the heart, or extracardiac, which will be heard outside of the heart, usually over the large vessels. Depending of time, we distinguish systolic and diastolic moments. Additional sound, which will be heard between first and second sound, are systolic. You understand? Murmurs, which is heard between second and first sound, are named as diastolic. Depending of mechanism, heart murmurs divided on organic or functional. We are talking about organic murmur when the turbulent movements of blood is provoked by anatomic defect which appears into the heart structures or into the large vessels. We are talking about functional murmurs which appears without anatomic heart defect and connected with characteristic of blood, its viscosity, its speed. And murmur characterized depending the character, loudness, length, character of murmur, they intensify or diminish. And when we'll give all these murmur characteristics, we can decide what is cause of murmur and can give the patient adequate treatment. To determine cause of murmur, we must give them definite characteristic depending location, time, and character. To understand mechanism formation of murmur, we must know causes which provoke turbulent movements of blood, because we remember murmur, it is audible turbulent movements of blood. And if you see on this picture, you see normal vessels which has tubulous form, along which blood go with inaudible laminar movements. If on the way of blood orifice of the heart or lumen of vessels narrowed, this process is called stenosis. Blood go through the narrowed orifice or lumen to normal path, which becomes widened for them, will do turbulent movements. Maybe opposite problem. Orifice not change, but other part of the vessels above orifice dilated, and again lumen along go the blood change its diameter, small and large. which is provoke factors, turbulence, blood movement. Other word, first cause of murmur formation is changing lumen of the vessels or diameter of orifice through which blood goes. Other provoke factors, which is changing speed of the blood, and if the intensity of the blood flow increases, it will go with turbulent movement. Which is characteristic for the patient with anemia, with cytotoxicosis. As a result, turbulent movements of blood will be heard as a murmur. And on this picture, you see turbulent movements of murmur of blood, which is heard as a murmur. Next problem, which also may be provoke factors of murmur, usually characteristic for large vessels. You know that health vessel resembles tube with same diameter along which blood goes with inaudible laminar movement. Vessels narrow width, we are talking about coarctation, lumen change, blood go with turbulent audible movement. Vessels widen it, we are talking about aneurysm, and again lumen change, blood go with turbulent movement. If you see on these vessels into which is formed atherosclerotic plaques, which narrow with lumen of the vessels on some way, and again blood goes through the part of the vessels which affected with atherosclerotic plaques will go with turbulent audible movement. Problem into the vessels, narrowing or dilation of its lumen due to coarctation or aneurysm or formation of atherosclerotic plaques, provoke turbulent movements of the blood, which is heard as murmur. We said that determine cause of murmur, we must give its full description, and first of all, depending location. Over heart apex, over aorta, pulmonary trunk, tricuspid valve projection, or any other auscultative point. Then, we'll pay attention when murmur is heard, after first or after second sound. And we remember murmur, which is heard between first and second sound, is called as systolic. Murmur, which is heard between second and fourth sound, is called as diastolic. Then we'll pay attention on loudness of murmur. Murmur may be loud or soft. Obligatory will determine its duration. It must be heard short time only at the beginning of systole or diastole at the end of systole or diastole, or maybe holosystolic or holodiastolic. Quality of the murmur. If you see on this picture, you see that shape of the figure which characterized murmur is different. If we see on this murmur, it is short decrescendo murmur, also short decrescendo, it is short crescendo, intensified at the end. Murmur may be intensified, then diminish, diamond shaped murmur. Murmur may be same intensity during whole period. Murmur may diminish or then again intensify. May be combined systolic and diastolic murmur, systolic crescendo, diastolic decrescendo. All these characteristics will help you determine cause of murmur, determine each is organic or functional, because you remember organic murmur appears due to anatomic defect and may be released only with some surgical manipulation. Functional murmur appear due to changing properties of the blood or functional heart activity. It may be corrected with therapeutic measures and completely released after some time due to effective treatment. We said about classification of murmur depending the location. Endocardiac murmur appears into the heart chamber, and first of all, it is connected with anatomic heart defect, narrowing of orifice, which restrict blood flow, or unclosed heart valves, which provoke abnormal comeback blood flow. We are talking about regurgitation. Endocardiac murmur may be functional origin when there no anatomic heart defect, but some valve, for example, mitral valve, cannot be completely closed. We'll stop on this problem later, but relative mitral valve insufficiency is provoked factors of endocardiac functional murmur. Same functional mechanism has Flint murmur, on which characteristic also will stop later. Muscular murmur appears due to affection of heart muscles. It may be myocarditis, myocardial infarction, and depending effect of treatment, this functional murmur can be released completely or can be corrected but not completely, and will change only its intensity, because intensity of murmur indicates about activity of blood flow through the affected blood vein. And anemic murmur may be heard over all auscultative point, over heart point, we are talking about its endocardiac mechanism, and sometimes over peripheral vessels. It will be assessed as extracardiac murmur. Extracardiac murmur, first of all, it is pericardial friction murmur, murmur which appears outside of the heart muscles due to audible friction of pericardium. Pleurapericardial friction murmur. Murmur which appear due to audible friction of the heart and lung. And vascular murmur, which will be auscultated over peripheral arteries. And we'll stop on characteristic all these murmur because every question will be given separately on exam. I separate anemic murmur because if you was attentive, I explained to you if it is heard over heart points of the heart valves, it's assessed as endocardiac. If it will be heard over peripheral vessels, it will be assessed as extracardiac, combined murmur. To understand mechanism, first of all, endocardiac murmur, I'll again come back to characteristic of systolic and diastolic period because to characterize murmur and find its origin, you must clearly understand and know direction of blood flow during systolic and diastolic period. And you must know what valve must be opened, what closed. Systolic period, active contraction of the ventricle and ejection of blood in greater or lesser circulation. Semilunar valve must be opened, aortic and pulmonary trunk orifice must be definite normal size. In this case, blood ejected and go with inaudible process. Will show only process formation of the first heart sound, which is closing of atrioventricular valve, contraction of muscles, and vibration of initial part aorta and pulmonary trunk. Then blood go with inaudible laminary way. If the orifice narrow width, blood ejected and go over aorta and pulmonary trunk with audible turbulence movement. Will have systolic murmur over aorta or pulmonary trunk. If during this period tricuspid and mitral valve will be unclosed, together with normal direction, blood come back into the atrium, but through the unclosed valve, through the slit. And again, it will be heard as systolic murmur, but only over heart apex and xiphoid process, because it is a regurgitated murmur. Let's see on diastolic period, heart relaxed. Aortic and pulmonary trunk valves must be closed to prevent comeback blood flow, because after ejection of blood, pressure in the heart ventricle less than into the vessels, and if valves unclosed, blood easy come back into the ventricle and will be heard as diastolic murmur over aorta and pulmonary trunk through the unclosed semilunar valve. Normally, during diastolic period must be opened atrioventricular valve, mitral and tricuspid, that blood can easily go into the ventricle. Orifice must be definite diameter. If the mitral or tricuspid orifice narrow width, blood goes with audible turbulence movements. We can hear diastolic murmur over heart apex or xiphoid process. Again, if we'll hear systolic murmur over heart apex, it may be result unclosed mitral valve, regurgitated murmur. Systolic murmur over aorta due to narrowing aortic orifice, aortic stenosis. Systolic murmur over pulmonary trunk due to pulmonary stenosis. Systolic murmur over xiphoid process due to tricuspid regurgitation. Diastolic murmur over heart apex due to mitral stenosis. Due to over xiphoid process due to tricuspid stenosis. Diastolic murmur over aorta due to aortic regurgitation, over pulmonary trunk due to pulmonary regurgitation. If this picture will be held in your brain and you easy see systolic and diastolic period, when I'll ask you on exam about murmur, you can easily explain its origin. For example, systolic murmur over heart apex only due to mitral regurgitation. Systolic murmur over aorta, aortic stenosis. Diastolic murmur over heart apex, mitral stenosis. Diastolic murmur over aorta, aortic regurgitation. Same process over right ventricle and pulmonary trunk. Now let's stop on the mechanism formation of organic and functional murmur and give it separate full characteristic. Organic systolic murmur over heart apex appears due to comeback blood flow through the unclosed mitral valve. Mitral valves cannot be completely closed due to they diminish because pathological growth of connective tissue as result formation of anatomic heart defect, which is called insufficiency mitral valve, depending its pathomorphological characteristic, and mitral regurgitation depending hemodynamic characteristic. Will hear turbulence movements of the blood through the unclosed mitral valve during contraction of left ventricle. Organic systolic murmur will be heard over aorta due to narrowing aortic orifice, again due to anatomic heart defect because pathological growth of connective tissue and formation heart defect, aortic stenosis, blood ejected with audible turbulence movement. If we are talking about mitral regurgitation, let's remember full auscultative picture, heart apex during this heart defect. Blood during systolic period, when the blood can go only into the aorta, it's come back into the left atrium through the unclosed mitral valve. Will auscultate heart apex where must be given characteristic of the first sound. We know first sound intensity depends from the force with which closed atrioventricular valve and contracted ventricle. Blood come back during systolic period, overfilled left atrium and increased blood volume come back into the left ventricle during diastolic period. To take this blood, left ventricle dilated to eject it, compensatory hypertrophy. As a result, both valvular, because unclosed valve, and muscular, due to dilation and hypertrophy left ventricle, components of the first sound will be decreased. Intensity of the first sound decreased. Will not see two times comparing with second. First sound decreased and will have whole systolic, all systolic period blood come back in left atrium, because all time during which left ventricle will be contracted, blood go normally into the aorta and come back into the left atrium. Will have systolic murmur over heart apex accompanied with diminished first sound. Our conclusion: patient can be sick with mitral regurgitation. Aortic stenosis also provoke fracture systolic murmur but over aorta. Will auscultate second interspace to the right of sternum. Due to pathological growth of connective tissue, aortic orifice narrowed and blood flow go with audible turbulence movements. Will auscultate aorta. What will you hear? Intensity of the second sound may be normal at the beginning and then progressively diminish in the progression of aortic stenosis, because intensity of the blood flow diminish, heart stroke diminish, systolic blood pressure diminish, and from systolic blood pressure depends activity, closing of the aortic valve. Second sound diminish. And will have specific diamond-shaped systolic murmur, holosystolic. All period ejection of blood is go with turbulence movements, but it's more intensive during medium of the systolic period. Isometric heart excitation. Then, if you remember, will be isometric relaxation of the heart. Intensity of heart contraction diminish. As a result, turbulence movements also diminish. It's intensified in medium and diminish at the end of systole. As blood ejected into the vessels and no any obstruction on this way except narrowing aortic orifice, will easily show activity of the turbulence blood movements, which intensify and then diminish. We are talking about crescendo, decrescendo systolic murmur or diamond-shaped systolic murmur over aorta. Is characteristic for aortic stenosis, anatomic defect, organic murmur. Diastolic organic murmur also is caused by anatomic defect If it is hot over hot apex, it appears due to narrowing mitral orifice, which restrict blood flow from left atrium into the left ventricle. Cause again pathological growth of connective tissue, which narrow mitral orifice. If the diastolic moment will go over aorta, we are talking about aortic regurgitation, which appears due to incomplete closing aortic valve, insufficient valvular aorta, because connective tissue diminish size of semilunar valve. They sclerose and cannot completely close aortic orifice. Diastolic moment over hot apex is hurt due to mitral stenosis, over aorta due to aortic regurgitation. Same process will be over pulmonary trunk and tricuspid valve. Mitral stenosis. Mitral orifice narrowed, I said you, due to pathological growth of connective tissue. Blood flow from atrium into the ventricle restricted. Incompletely filled left ventricle, easy contracted, and will have increased or loud force sound, which intensity more than 2 times comparing with second. Then blood go into the left ventricle, and at the end of diastole, pre-systolic period, due to contraction of left atrium, intensity of blood flow and intensity of turbulent movement increase. As a result, will have crescendo pre-systolic diastolic moment over hot apex. Intensity of the moment depends from intensity turbulence blood movement, and it's more intensive at the end of diastole when the blood pushed due to active contraction of left atrium, and then more intensive contraction, then more loud moment. Crescendo pre-systolic diastolic moment over hot apex, accompanied with loud first sound, is characteristic for mitral stenosis. Aortic regurgitation. Due to growth of connective tissue, aortic valve sclerosed, diminish, and cannot completely close aortic orifice. During diastolic period, when the pressure into the left ventricle less than into the aorta, blood easy come back through the unclosed semilunar valve, will have diastolic moment over aorta, because it's connected with aortic valve. We'll put stethoscope right side of the chest, second in the space, and we'll have diminished second sound because no period closing semilunar valve, no valvular component, after which decrescendo systolic moment, because more intensive comeback blood flow at the beginning of diastole, and then when the pressure into the left ventricle increases, and left ventricle will be filled with blood because it is diastolic period, intensity of turbulent movements diminish and disappear, because you understand, if the blood come back all diastolic period, patient died, because blood ejected and come back, ejected and come back, no blood circulation. in aortic regurgitation will have short protodiastolic decrescendo moment over aorta, which accompanied with decreased second sound. I explained to you mechanism formation of organic moment over heart apex and aorta during systolic and diastolic period. If it's clear for you, you easy explain formation of moment over right heart chamber and pulmonary trunk. Because same mechanism, only glass opposite position. Functional moments. I said you, it appears without heart defect due to some dysfunction of the heart structures or problem with blood flow. Now let's explain mechanism formation functional moment in relative incompetence of the mitral valve. First of all, I want that you understand what is relative incompetence of the mitral valve. Incompetence of the mitral valve shows that mitral valve incompletely closed during systolic period. Relative shows that no anatomic defect. Size of the mitral valve normal. Why normal valve cannot close orifice? Because orifice widen it due to significant dilation of left ventricle. It may be when the left ventricle overfilled with blood. It's more characteristic for the patient with aortic regurgitation when the ejected blood portionally come back, but right ventricle ejected full definite blood volume, which must be hauled into the left ventricle. And left ventricle dilated to take all its blood. Together with dilation of muscle, dilated orifice, and health valve becomes incompetence for widening orifice. We are talking about relative because no anatomic defect, no diminish of the valve, incompetence of the mitral valve, which appears due to significant dilation of left ventricle. It may be patient with aortic regurgitation, anatomic defect over aorta, over heart apex, functional problem, or patient with dilated cardiomyopathy. You see, ventricle dilated, muscle becomes thin, health valve becomes incompetent for this orifice. During systolic period, some blood come back into the left atrium, come back with audible turbulence movement. Over heart apex will be heard systolic functional moment due to relative incompetence of the mitral valve. Auscultative picture resembles true mitral valve incompetence or mitral regurgitation because intensity of the first sound diminished because no valvular and weakened muscular because weak dilated muscle and holosystolic moment. All period of contraction, left ventricle, blood come back into the left atrium. Functional or organic moment. We can clear depending of ultrasonography, anamnesis of the patient preceded diseases, and effect of treatment. We'll talk about it later. Cause formation of relative mitral valve incompetence. I said you aortic regurgitation plus blood or dilated cardiomyopathy. Flint murmur which appears due to relative mitral stenosis. And again, mitral stenosis, mitral orifice diminish relative because not due to anatomic defect, no pathological growth of connective tissue. Let's see why mitral orifice narrow width. Let's remember heart defect aortic regurgitation. If you see on this picture, you see aortic and mitral valve localizes on same level. Patient with aortic regurgitation, aortic valve cannot be completely closed during diastolic period. As a result, blood come back into the left ventricle. Come back turbulent blood flow push on the caps of the mitral valve, which rise. As a result, mitral orifice narrow width on the size of the one caps of mitral valve. Relative stenosis. No growth of connective tissue, no problem with mitral valve. They open and then one cap come back due to come back regurgitated blood flow. Mitral orifice narrow width, blood flow go with turbulent movement, which will be heard over heart apex. Aortic regurgitation will be heard over aorta. It's anatomic defect. A diastolic movement through the narrow width mitral orifice will be heard over heart apex, and it is called as relative mitral stenosis Flint murmur. Flint it is author which described this murmur. If you see on this graph, you see that after second sound will be heard decrescendo protodiastolic murmur, because if you remember aortic regurgitation, blood come back also only at the beginning of diastole. Then no come back blood flow, valve completely open and blood go with inaudible, normal laminar movement. Short protodiastolic decrescendo murmur on over heart apex, which accompanied with diminished fourth sound because in aortic regurgitation left ventricle hypertrophy, intensity of the fourth sound decreased due to decreased its muscular component, is characteristic for Flint murmur. I want to remember you organic mitral stenosis murmur presystolic crescendo and accompanied with increased fourth sound because left ventricle not affected. Blood volume in its chamber decreases due to true mitral stenosis. And if you hear protodiastolic murmur with diminished fourth sound, it is Flint's murmur due to a relative mitral stenosis. If you hear presystolic crescendo diastolic murmur over heart apex accompanied with increased loud fourth sound, we are talking about true organic mitral stenosis. Other functional moment which not connected with heart valves or orifice, anemic moment. Moment which appears due to change in blood properties. Anemia, decreased level of red blood cells. If you remember physiology, cells components of the blood mainly formed from red blood cells because they presented into the health blood 4 to 5 times 10 in 12 degree per liter. And if the level of red blood cells decrease, blood becomes liquid. Its viscosity decreased. A liquid blood go with more intensive movement, which will be heard as turbulent audible murmur. If it's caused by anemia, we are talking about anemic murmur. I'll pay your attention. Cause of murmur, properties of blood. As a result, anemic murmur will be heard over all heart points because it's connected with blood, not with heart structures. We'll put stethoscope over heart apex, over heart base, over xiphoid process. We'll hear systolic murmur. We'll hear turbulent movements of the blood during the active movement. More intensively, murmur will be heard over heart base because blood pushed due to contraction of ventricle into the lesser or greater circulation. Anemic murmur over heart apex. Systolic murmur. Intensity of the sound may be normal because it's not connected with heart. Muscular murmur. Also functional murmur. It will be heard only over heart apex because it is caused by affection of ventricular muscle, usually due to the inflammation, myocarditis. As a result, muscular component of the first sound will be decreased. And due to affection of muscles, process of isometric excitation and contraction disturbed. And sometimes heart cannot be simultaneously excited and contracted. And before full excitation of the heart muscles, blood moves into the heart chamber and will show its turbulence movement into the ventricle. But this process short only at the beginning of systole, because later heart muscles completely excited, contracted, and blood ejected through the normal aortic orifice with inaudible laminar movement. Muscular murmur will be heard only at the beginning systolic period. Over heart apex, it has decrescendo character and accompanied with diminished first sound because affected its muscular component. You see, same time systolic murmur, but depending its quality, depending its duration, depending characteristic of the first sound, we distinguish organic, functional, anemic, muscular murmur. Properties of murmur helps you determine its origin and send the patient on definite examination, clear disease, and give correct treatment. Because if we think about anemic murmur, what additional examination is needed? Blood analysis. we'll see level of red blood cells decreases, viscosity of the blood decreases. We know it is anemic. Mom will prescribe anemic therapy. Level of red blood cells come back to normal. Mom disappears. We seen about muscular mama. We'll send our patient on echocardiogram. We'll see that density of the muscles change. Maybe change its thickness. Maybe decrease heart stroke because weak contraction of affected muscles. We know problem with muscle. Moma due to affection of muscle. Muscular moma will give medicine which release inflammatory process into the heart muscles. Elasticity of the heart muscles come back, moma disappears. I won't stop on the questions. Differentiation of the moma. First of all, we decide its organic or functional origin. First of all, depending its time. Organic moma may be both systolic and diastolic. You remember, we said about regurgitation, about ejective moma, systolic and diastolic, both. Functional moma, mainly systolic. Remember, relative mitral incompetence, anemic, muscular. Systolic. Only one Flint's moma is diastolic. Because functional moma correlated with blood flow, which depends from blood properties and activity of contraction heart muscles. Then length. Organic moma, permanent. They hold all period and cannot disappear. Functional moma, not permanent. They may be more better or badly auscultated, sometimes hot, sometimes disappear and then come back. Organic moma usually long and loud because blood flow go through the defect of the orifice or vessels lumen. Functional moma usually short, soft and blowing, more comfortable for our ear. Organic moma obligatory accompanied with other signs of heart defect. Changing heart body, changing heart sound. You see every moma accompanied with other signs of heart affection. Functional moma not tightly correlated with this characteristic. For example, in anemia, sound may be normal, heart bodies not change. Organic moma obligatory irradiate in other side of the body, from heart apex into the ampute 0 point in mitral regurgitation, on carotid artery in aortic stenosis, onto the Botkin air point in aortic regurgitation. Functional moma, local. They haven't irradiative sites. Organic moma increased after treatment. Why? Because if you remember, I said you organic moma, it is anatomic heart defect which cannot be compensated with therapeutic method. But narrowing of orifice or incomplete closure of valve disturb hemodynamic. As a result, involve heart chamber in pathological process because they overloaded due to abnormal hemodynamic. See, hypertrophied or dilated, and intensity its contraction decreased. Patient come to the doctor, therapeutic doctor, with symptoms of heart failure because decreased heart activity. Will prescribe treatment, cardiotropic medicines, which increased elasticity of the heart muscles, as a result increased its contractive ability. If the contraction of the heart increases, blood will be ejected with more intensive force. As a result, more intensive turbulent movements, loudness of the sound increases. It shows that you correct activity of heart contraction. Functional movement decreases or disappears after treatment because it's functional disorder which may be corrected with therapeutic medicines. Will increased level of red blood cells, anemic moment disappears. Will release inflammation of heart muscles, muscular moment disappears. Result of treatment. Auscultative characteristic of MOMA helps you differentiate its organic or functional origin. Other problem which may be during heart auscultation. You auscultate the heart and you hear MOMA over heart apex and over aorta also. You must decide. It is one problem which irradiates over all heart region, or it's two separate heart defect. We are talking about combined heart defect, anatomic defect over heart apex and over aorta, or organic process over aorta and complication functional disorders over heart apex. To differentiate, what will you do? You put stethoscope over first point over heart apex because we'll start auscultation from the heart apex and gradually move it to the aorta and pay attention on intensity of the moment. If the moment decreases, it shows only problem with mitral valve and orifice, which transmitted over all heart region. Opposite, moment intensified to aorta, process localizes over aorta. Maybe other way, moment decreases and then again intensified. It shows two heart problem over heart apex and over aorta. Depending intensity of moment decreases mitral valve, increases aortic valve, decreases then increases combined mitral aortic heart defect. Extracardiac moment, pericardial friction moment, audible friction of pericardium lathe. Its mechanism resembles pleural friction moment. Helps pericardium lathe smooth and slightly lubricated that its movements will be inaudible. Will have friction moment because pericardium lathe become dry or rough. We are talking about dry pericarditis. Pericardial friction moment appears of the patient with dry pericarditis due to audible movements of pericardium. It will be heard both systolic and diastolic period, and it is better heard if we'll put stethoscope over area absolute cardiac dullness. Absolute cardiac dullness is part of the heart which not covered by lung. It is open part of the heart, which localizes along left eight of sternum, third, fourth interspace. Botkin air point. We'll put stethoscope Botkin air point, area of absolute cardiac dullness. Ask the patient slightly inclined in front to push hard to the chest and deeply exhale and stop breathing. Lung collapse, heart more open, tightly pressed to the chest, friction movement, very easy heard during both systolic and diastolic period. When you'll answer on the question about pericardial friction moment, you'll name that it's caused dry pericarditis. It's better auscultated in the Botkin air point, area absolute cardiac dullness, when the patient slightly inclined upward and hold breathing after deep exhalation. Pleurapericardial friction moment is caused due to audible friction lung over the heart. Maybe both problem with lung and heart, pleurisy pericarditis, which appears in some immune diseases. Maybe only due to pathology of the heart or only pathology of the lung. When the heart and lung tightly connected, surface of pleura or pericardium becomes rough and or dry. Pleura-pericardial friction moment. Also will be heard during both systolic and diastolic period, but it's better heard over heart apex. Relative cardiac dullness when the heart covered with lung. We put stethoscope over heart apex and ask the patient hold breathing after deep inhalation because lung expanded, tightly pressed to the heart, and pleura-pericardial friction moment becomes better heard. Pericardial friction moment, position of the stethoscope Botkin air point, patient hold breathing after deep exhalation. Pleura-pericardial friction moment, stethoscope over heart apex, patient hold breathing after deep inhalation. And last, we finish auscultation of the heart. Let's formulate full conclusion. I'll again remember you. During heart auscultation, we'll pay attention on number of tones, which normally must be 2. The rhythm, which must be regular. We'll count heart rate, which varied from 60 to 80 beats per minute. We'll give description of sound and pay attention on additional sound, which will be assessed as additional tone or murmurs. Our conclusion for the health people. On heart auscultation, 2 sounds are heard over all points. They are rhythmical, cardiac rate 72 beats per minute. At the heart apex, at the base xiphoid process, first sound 2 times larger than second one. On the heart base, second sound 2 times louder over first one. splitting, reduplication, accent of the second sound, and murmur are absent. It shows that no problem with hat. Such conclusion you will give on exam when your question will be auscultate the hat with definite order and give conclusion. Such conclusion you will give when you will answer final exam on this after 6 course. And last question on which I want to stop today, it is auscultation of vessels. Peripheral vessels, large vessels, may be auscultated. And on exam will be given questions about auscultation some or other peripheral vessel. Will auscultate carotid artery under the mandibular in carotid triangle. Will auscultate jugular vein in supraclavicular fossa above clavicle. Will auscultate abdominal aorta 2 centimeters above the navel and 2 centimeters to the left from them. Will auscultate renal arteries 2 centimeters above the navel, both right and left side laterally from linea alba. And will auscultate femoral artery in the position of ilioinguinal ligament. Carotid artery is auscultated only one case, patient with aortic stenosis. Will remember cause of carotid artery along branch sternocleidomastoideus muscles medially to the neck. Will put stethoscope immediately under the mandibular, usually right mandibular, because each is aortic arch from which will be separate right carotid artery, where better heard turbulence movement of the blood, which appears over the aortic orifice when the blood ejected through the narrowing aortic orifice. Carotid artery auscultated at irradiative point, patient with aortic stenosis. Jugular vein auscultated above clavicle, point where jugular vein enters in vena cava superior, and murmur may be heard only patient with anemia, because liquid blood which enters from small lumen of jugular vein into the large lumen of vena cava superior will do turbulence movements, resemble movements of top child play. And sometimes each is named as top murmur or anemic murmur over jugular vein. Will put stethoscope above clavicle. Not mixed. Carotid artery under mandibular, jugular vein above clavicle. Carotid artery patient with aortic stenosis, jugular vein only patient with heavy anemia, when blood very, very liquid, very low level of red blood cells. Abdominal aorta, auscultated 2 centimeters above the navel and 2 centimeters to the left from linea alba, along course of abdominal aorta. We put stethoscope and we can hear murmur due to changing lumen of abdominal aorta in its aneurysm or opposite coarctation, or due to compression of the abdominal aorta with some abdominal organs. Usually, murmur of abdominal aorta will be heard of the patient with tumor of pancreas, head of pancreas, which push on aorta and compress it, narrow it, its lumen, and provoke audible turbulent movements of blood. Abdominal aorta auscultated 2 centimeters above and to the left from the navel. Murmur will be heard in its aneurysm or compression. Renal arteries. Auscultated 2 centimeters above the navel and 2-3 centimeters laterally from linea alba to the right and to the left, because two renal arteries. We'll auscultate renal arteries to reveal murmur, which may be caused only one problem: stenosis of the renal arteries, anatomic defect. How we can know about it? It is characteristic for patients with arterial hypertension, which appears in younger people, usually in childhood period, and not response on usual hypertensive medicines. Will increase dosage, will combine some medicines, no effect. Will auscultate renal arteries, may help murmur. We can see about possible stenosis of renal arteries. Send our patient on Doppler echocardiography of vessels or angiography of renal arteries, because this problem may be decided only with surgical method, transplantation or restenosis of renal arteries. Because from physiology, you know, when the renal kidney circulation decreases, the responses with activization of juxtaglomerular apparatus, active synthesis of angiotensin, renin, which increased tension of peripheral vessels, and as a result will be increased diastolic and then later and systolic blood pressure also. And last vessels which will auscultate, femoral arteries. They auscultated above ilioinguinal ligamentum. We'll put stethoscope above ilioinguinal ligamentum. Patient with aortic regurgitation to reveal two phenomena: double Traube sound, Traube is water, and double Vinogradov-Durazier murmur. Mechanism formation of double Traube sound. When we'll carefully put stethoscope above ilioinguinal ligamentum on projection of femoral artery, we'll hear as blood flow push on the vessel due to heart contraction and ejection of blood in greater circulation, vessels dilated, one sound, and then due to come back blood flow, vessels collapse, and will have vibration during dilation and collapse of vessels, which is called a double Traube sound. If you artificially compress vessels due to pressing stethoscope on the vessels, its lumen will be artificially diminished and will provoke turbulence blood flow. In this case, we'll have double Vinogradov-Durazier moment. Turbulent movements during systolic and then during diastolic period. Femoral artery, auscultated only in case aortic regurgitation, will put stethoscope above ilioinguinal ligamentum slightly to listen vibration of vessels, double Traube sound. Then we'll press to auscultate double Vinogradov-Durazier moment. That's all today, all information which I want to give you. Thank you so much for your attention. Goodbye. Be healthy.